So the next session is about pay for performance. It's actually about quality measures for which we will shortly be put on the list of pay for performers. But for now, it's not quite that for us. It's for our hospitals for the most part. But as you know, Medicare has come up with a whole list, and of course, whatever Medicare does, the insurance companies will be sure to follow in due time. And this is going to affect all sorts of pay for our hospitals and ultimately will affect pay for us and our physicians, et cetera. Some of this not so good, some pretty good. Billy's going to sort of lead the discussion. There is a chapter on this, but again, we're going to try to raise the bigger issues rather than just the specifics.
The chapter that Rick put together for this, so this is something that Rick Bucata, who's been running some of the business elements of this course for many years, is very interested in. The chapter, by the way, I have to tell you, you will not find this information gathered in this fashion in a comprehensive way any other place.
This was worth the cost of your meeting fee.
So he points out that there's a couple things about pay for performance and these criteria, and the first of that is that it's a moving target, that CMS is definitely ramping up on this. As was indicated, right now it's mostly directed at hospitals and their reimbursement, but it's coming directly at us as well at the front line and the practice end, and pretty soon they're going to be querying patients about how nice you are and whether those kinds of things. There's going to be some physician elements of it. Before we get into the papers and start talking about some of the bigger issues, as Jerry said, that are here, I would point out that in the med legal section, abstract number 5, is it, I think? 5, we didn't talk about it a lot, deals with one of the questions that's out there, which is if part of the public domain is the collection of pay-for-performance data, which means there'll be a bell curve. In your hospital, they'll know which doctors get the antibiotics up in 4 hours, which ones don't. The question is, could that pay-for-performance data be used against you in a specific medical legal case? Could the lawyer subpoena the pay-for-performance data and say, oh, Dr. Brown stinks, here's more evidence of how bad he is. He's at the bottom of the bell curve of the hospital for these pay-for-performance criteria. Fortunately, abstract 5 in the med legal section says that it would really be hard to enter that data into a court of law in a specific med legal action unless you could prove the pay-for-performance criteria's relevance to that case. And so they say, relax, you got plenty of reasons to be paranoid and upset and asking whether or not these pay-for-performance criteria are evidence-based, et cetera, but they're probably not going to be used in that venue. So that's reassuring. But they do say at the end that if you're in trouble with your state licensing board, if you had some issue that came up with your state licensing board, the state licensing board is under no such restrictions regarding these pay-for-performance criteria and might use them in that regard. So from our med legal case, probably not a valid concern right now, but for a state medical board issue, possibly a concern for licensure. So that alone, I think, is a reason. Your hospital administrators, as soon as someone talks about hospital revenues and pay for performance criteria, you know that your hospital administrators will want compliance to be high, and if you're not a player in this, you're going to be perceived as a problem. That's just the business world as it is. The next thing we're going to look at a little bit, and the panel's going to jump in, Diane has been specifically involved in some brouhahas in this regard, but we'll get to that one in a moment. She was involved in the pneumonia brouhaha for pay for performance. We're going to talk a little bit first about the cardiac pay for performance criteria, and one of the questions that practitioners have is most of us bridle, I know I bridle, at the thought that CMS is going to tell me what I have to do. And the first question I have is how are they saying this? Is it really evidence-based? And so there's a variety of them for cardiac patients that are pretty easy to deal with regards to quality and pay for performance. And many of them, you got to decide, I think, in medicine, which windmills are you going to tilt at? Some are worth, some are not. But with regards to AMI, acute myocardial infarction, and acute coronary syndromes, aspirin on arrival. I can live with that. I think the evidence is pretty good that aspirin, unless someone has a true aspirin allergy, I can live with that. And it's probably right for CMS to step in and say, you really got to do this. This is such a good, such a cheap, such a cost-effective thing. And there was evidence that it wasn't being done that well. I think the evidence they were responding to was, 15, 20 years old. But I got no problem with that one. I can live with that, Jerry.
Well, I was just going to say, before we actually talk about the specifics, let's just talk about the concept. So on the one hand, it's really easy for us to get really mad that somebody's trying to tell us how to practice medicine. And I personally have lots of problems with this process that will come out as we talk. But I do think we should acknowledge that there's a good reason for this process to have started, which is there's huge evidence of tremendous variability in practice, some of which can be explained by, there isn't really a better answer, and people should be able to. Some can be explained by different patients, different environments, but some of it's really hard to explain. There are some things we know that sometimes lots of people aren't doing. So the notion that we should have some ideas about what is really a good process is, of course, reasonable. The problem is that the devil's in the details. Who gets to decide on what basis? Is it a drug company saying that they want to make sure that clopidogrel is part of the process because they want to sell clopidogrel, and they hire an expert to be on the panel who says, oh, yes, you must do it? That's it. Those are very different questions. And that's where I think the rubber meets the road, is what are the details? But I do think we should acknowledge that, of course, it would be fine to have process measures if they really were robust. And that would help us. All of us make mistakes. For every one of us, there are things we don't know. And gee, if they said, you really should do this in pneumonia, and it really was the right thing, I'd be all for it. The problem is who gets to decide and what happens, and how often are you allowed to say yes in general, but not in this case. And the other sort of general comment I wanted to make before we do this is that all of these are about process measures rather than outcome measures. And, of course, that's a little crazy in one sense. On the other hand, we should also acknowledge that there is a reason for that. It's really hard to measure outcomes. It's hard to measure differences in death. You'd have to take huge samples to show, 0.1% versus 0.2% might mean you're killing everybody who you could have saved. But you'd need a lot of patients to do that.
And particularly in the emergency room.
And
how are you going to tie the patient spends 8 days at home sick, and then comes into the hospital, spends 7 days in the ICU, a day in the operating room, 5 days on the ward, yet your 4 hours in the emergency department are supposed to be the determinative outcome? So specifically for emergency medicine, we're almost always stuck with process measures rather than outcome measures, because it's hard to tie what happened in those 4 hours in the emergency room to the ultimate outcome, even if there are outcome differences.
Right, but the flip side to remember is that it still is important, because it's easy to come up with process measures that sound right, but which may turn out to have really no importance in human outcomes. In other words, we just did a study this month, yesterday we did the tape, where they looked at the process measures for pneumonia, congestive heart failure, and MI, the big three that CMS keeps doing, and they looked at thousands of hospitals, and they looked at the best hospitals that did all the right things and the worst hospitals that did all the wrong things, and there was no difference in outcomes. So, and the conclusion of the authors was, maybe we need to do a better job of finding process measures that are useful. So, yes, they have to do it, but like all of these things, this is a mixed deal. It's very easy to come up with measures that don't measure anything that's important.
Go ahead.
Well, I like the first example you give of pneumonia as a process measure. The question isn't, is it pneumonia or not pneumonia? The question is, are they hypoxic tachycardic, and whether they get the IV antibiotic.
So you're making another point, which is that we tend to lump. It's much easier to lump. It's much easier to measure pneumonia or one of the examples is time to lytics in AMI. Well, time to lytics is really important. If you clutch your chest, you're having an MI, you're in the first 20 minutes, every minute counts. If it happened yesterday and you finally came in, I had 6 hours of pain, minutes don't count at all. But we lump them all. So sure.
Same with pneumonia. Some
Hyperacute
pneumonias you
sick
could treat
pneumonia.
next week, and they'd be fine.
So that's these are all nice ideas, but there are all sorts of threats to them, and that's what we're going to spend a little time talking about.
So, and one of the things that also has been brought up when we've done this previously, and I mentioned aspirin, Almost every time we do this, somebody in the audience raises and say, yeah, we were dinged for the aspirin thing. And it was like, the people are so stupid, they don't even know how to measure it. We weren't giving aspirin in the emergency room because our pre-hospital care system gives aspirin. If they just had the, two neurons connected together with a spirochete, they would have looked at the pre-hospital care record and seen that the people got aspirin. But because that wasn't part of their data collection, our hospital got dinged for this as a poor performer when in fact everyone had received aspirin. So that's the other issue that comes up as part of the bridling with this is that by the time they're going to start linking your pay or your hospital pay to it, people say, I really want the things they're measuring to be validly measured and actually looked at. I don't want to get spanked for doing a bad job when in fact we did a great job because they didn't look at the pre-hospital care sheet. And then you start getting into bureaucratic intelligence and how well it does these things if they're, that's kind of an oxymoron, but there you go. And so everyone agreed with aspirin, but there are groups that have been dinged for aspirin because they didn't look at the pre-hospital care setting, because not all pre-hospital care systems give aspirin. In Los Angeles, they do. And what it does to emergency medicine, in emergency medicine, we have like the smallest chart on the planet, right? We're kind of proud of it. We like to, please don't add a second page. That's good for me. And so one of the things about it is we tend to chart only positive things. I'm not in the habit of charting what I didn't do. Aspirin not given, see paramedic note. But that's what you need to do to keep CMS out of your face on this, is it changes some of the charting strategy. You have to know what the pay for performance criteria are so that you can get in a habit of the absence of charting. Or you might say beta blocker not given, blood pressure 60 over palp, cardiogenic shock.
This is only a tip of the iceberg as far as negative charting. It's down the pike. There will be much more negative charting you're going to have to do to explain why you didn't do certain things. We'll get into it as we go through this chapter, but there are more of them coming down the pike. Your charting will be different.
You already chart that they don't have on their review of systems.
Right.
They don't have orthopedic stuff for they came in for a headache. I mean, this is the world we live in, and I suspect some of you out there are people who are now creating new pay-per performance or CMS process measure templates that you're going to have to, they're going to be selling us because you want to get paid, you have to have checked off beta blockers one way or the other, and this is going to remind you that on every chart there has to be a note, yes, I gave beta blockers, no, I didn't because X.
Go ahead.
In my right upper hand corner of an AMI, I just put when the aspirin was given. The patient took it or the EMS gave it, so it's like right there.
Right, and that's smart. Yeah, that's really smart. But if you didn't think to do that, somebody's going to. In the same way that in the pneumonia stuff we'll get to in a minute, but a lot of it has to do with in 4 hours. What about if they came in, they had blah, 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 they went upstairs, they had their surgery, they had a post-operative pneumonia. They were seen in the ER, and they didn't get antibiotics in the first 4 hours. There are actual things like that where the hospital diagnoses pneumonia. How come you didn't give antibiotics? Or you diagnosed a PE, and the next day somebody said, we're considering pneumonia. And the chart reviewer went through and said, rule out pneumonia.
Final diagnosis.
You didn't give an antibiotic. So there are lots of ways in which this is crazy.
And you'll see. So aspirin, I think we can all live with. We all agree that data is robust. We all agree that it's great stuff, that the downside is really negligible. And that's as far as we get. After that, it gets murky in a hurry. So the next one is, for ACS AMI, is beta blocker on arrival. Well, on arrival, do you really need a beta blocker? The evidence, if you go back over the last decade, and Jerry would probably say it more succinctly than me, but we all agree that beta blockers are good for people with acute coronary syndromes, but the marginal benefit is low, and no one has ever suggested that you need it on arrival. It's not like lytics. And so who needs beta blockers on arrival? Really, all of us would agree, I think, that the hyperdynamic, non-shocky, so the person who comes in, sweat pouring off their forehead, tacking at 110, blood pressure 160 over 105, who's having acute chest pain, obviously a beta blocker is a big plus for them because
unless it's contraindicated, which those often are, because that can be a sign of congestive heart failure, and so
assuming
you
their
got to be
lungs are
careful.
clear.
But I would actually be a little more cautious than Billy. I don't think it's quite obvious that beta blockers are good. I think it's obvious that beta blockers do some good things and do some bad things, and the devil's in the details. There are some patients who beta blockers help, the one who's hyperdynamic and doesn't get hypotensive from it. And there are some patients who it clearly harms, the patients who are not
Blocks,
hyperdynamic, doesn't
CHF.
help them, and they're at risk. They're going too slow, they're in heart failure, they have low blood pressure, and there are some in the middle where it's probably pretty much a wash. But I've never been convinced that there was good evidence that beta blockers are good for everybody. They're obviously not. They're a little bit beneficial. If your heart rate is fast, that's when, and they're having ACS, that's when beta blockers are useful.
So the routine sort of reflex approach to an acute coronary syndrome and acute MI, which used to, the old teaching sort of standard thing was 5-5-5 of IV metoprolol. No one ever said it had to be IV, could have been oral, but that was the standard approach. You had a hot chest pain patient, hyperdynamic 5-5-5 of metoprolol. I'm still okay with that for the hot hyperdynamic
Sure.
patient. But if you don't give it, and there are lots of reasons that you might not. They're an asthmatic, they're a COPD, or they have some evidence of failure, or they, whatever it is, there's a list. Now you're going to need to say why. Before you didn't have to say why you didn't give it. Now you're going to need to say beta blocker held for bradycardia and hypotension. Beta blocker held for, congestive heart failure or acute pulmonary edema. Beta blocker held because patients also in DKA and, maybe I didn't want to make it worse and add to their insulin resistance.
Or how about because they had no indication? Because chest pain by itself is, as far as I'm concerned, not an indication. For me, it's really important to give the patient who's going 90 a beta blocker.
And
Heart
then-
rate really does manifest myocardial oxygen demand, but not at 70.
Yep. And then there's this paper here, which I don't think we want to get into in great detail. It's the COMMIT trial. It's an enormous, which is in two parts. Part of it really ripped clopidogrel a new rear end. That part is fascinating, and Jerry's already talked about the clopidogrel farce. But this part of it looked at metoprolol. The Chinese MI patients, they had a very small portion of their population participate, only 45,000. MI patients in this trial. So it's a huge trial, but the Chinese system doesn't exactly compare. But what they found is that just what Jerry suggested, that beta blockers aren't a home run, they aren't universally applicable, and that in fact the Kaplan-Meier curves, the death curves, show some separation, adversely indicating if outcome's what you wanted to see. Here the outcomes were slightly worse with beta blockade if you gave them indiscriminately. And so the key point here is, yeah, beta blockers good for some. The lumping here, if you lumped them all together and said we're going to give beta blockers for everyone, you'll get in trouble. And that's what the COMMIT trial kind of says. So get used to treating. I don't think this changes who you treat with beta blockers. Treat all the people you would have before, the hyperdynamic ones where you think it will help. But when you don't use it, you better say why. And then it gets even murkier. If that wasn't murky enough, so we got aspirin, we can live with that. We got beta blockers, murky. You still got to use clinical judgment and begin to chart negatively when you don't give it and why. And then we get into time frames. And the time frames lump, just as Jerry said earlier, the concept that you have acute chest pain and you came right to the hospital. There's no breakdown in these time frames, door to balloon, door to cath, door to drug, if you're using lytics. There's no time frame breakdown for someone who's had a period of chronic stable angina and now is unstable angina and now is an acute MI, right? There, some people go through a continuous process from those three things. There's no attempt to differentiate that. It's just from when you hit the door to the intervention. We know, just as you suggested in the back, that lumping that all together is nuts. Any more than you could tell the outcome. The person who stays home and completes their MI and comes to the emergency room 3 days later because they're short of breath and they have failure, i.e. they have a complication of their MI, is totally different from someone who comes in with SD elevations that are acute.
But in any case, two parts of this. One is the average time for an MI to get to an ER after symptoms, about 6 hours. Now, some people get there really early, and those people we have to be hyper acute with, and the ones who get there later, obviously you don't. But in the way that Billy said before, I'm not terribly worried about this, even though it really is ridiculous for most of the patients. Very few of them do minutes matter, but nevertheless, it probably is a marker of your system, and So we should all aim to have a system, whether it's lytics or PCI, where we do it quickly. If you recognize a STEMI, you should do it quickly, even though it probably only helps a very small number of patients.
And I really like to have the stick because, in my opinion, the cardiology prima donnas need a good beating every once in a while to actually respond. The recent New England Journal paper that documented your chance of having a bad outcome from an MI in a weekend has nothing to do with the left anterior descending being a weekend vessel. It has everything to do with weekend lethargy on the part of our cardiology consultants. And the New England Journal's suggestion that the way we need to fix this is to pay the bastards more is absurd. We need to demand accountability from them. The concept that, they're already coming to work in a Bentley. I'm supposed to pay them more to get them to come in on the weekend? It's
So
absurd.
I have a question. How many, what do you think is the average number of these rants that Billy has per lecture? Is it like 3 or 4?
It's been suggested that if someone in the
Dart,
front
right?
row had a Haldol blow dart, it would slow down. But
we're
quite
voting for
frankly,
succinyl
I haven't
choline.
started on the
Drop
radiologists
him.
yet, but I'll get there later. But the suggestion that we need to pay the cardiologists more to get them to come in, I like the fact that we got these kind of criteria which demands accountability out of them. So although I don't think it's tremendously good medicine or process of care or things like that, I don't think the lumping is tremendously valid. To every dark thundercloud from the CMS comes one small silver lining. And this is the silver lining here, which is that it demands accountability from our cardiology colleagues. Moving on. Statins. Jerry, please weigh in.
Go for it.
So I'll just set the stage and then let Jerry fire the bullets. The question is that many cardiologists now will come in on your acute coronary syndrome patients and they'll write for a high dose of statins in the emergency room like it's aspirin. Like the benefit of giving a high dose statin now has something to do with the acute process. Now in the literature, and Rick provides a ton of papers for you to try and digest here, and they're difficult papers to understand. If you just took a quick casual read of them, you might think this is great stuff. The suggestion is that early high-dose statins, usually double dose, so 80 of pick the blah, 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 blah bid you want to give them, that when you give that to them, that there's some change in endothelial function and that there might be an early beneficial effect. But none of these studies were really designed specifically to look at that, and they're hard to tease it out. They do it to a limited degree. My feeling on it is if you're going to be on statins at the end of your MI or your stroke, so you're going to be on it for 10 years, I don't got a problem with your being on it for 10 years and 2 days. In other words, me starting it. So I don't have a problem with it. It's, 10 years versus 10 years and 2 days. That's not going to break the bank. You're probably going to end up on them anyway. If there is even some blank, possible explanation, and most cardiologists, how many of you have seen your cardiologists recommending this when they come in, start them on a double dose of whatever it is right now? Are yours, Di?
I don't trust ours, so I don't listen to them.
Ours are at LA
No,
County.
I don't mean to be,
Yeah.
we have a lot of our not a lot, 2 of our cardiologists who do a lot of these studies like the clopidogrel study. So they come down with their Plavix box and this and that and the other thing. So I don't necessarily follow their recommendations. I follow more what I've read.
And so they're the papers for you. And Jerry, I think, will try and give you some balance to it because I think
Well,
Jerry
no,
understands it
I
as well.
think this is a complicated topic, and statins is something that I think is widely misunderstood what its value is. In a very brief nutshell, the value of statins depends very little on lipids, and it depends entirely on cardiovascular risk. And so when you're talking about acute MI patient, they fall into the high-risk group, and most of them, almost all of them, should ultimately be on a statin. And so I have no problem with this as a notion. On the other hand, it's quite clear to me, reading these articles very carefully, that there is no added benefit to giving it now versus tomorrow. And what's more, there's probably no added benefit. I'm pretty sure there's no added benefit of higher doses, and that what this is really about is selling more drugs and pushing more drugs. But this is the group where it's the least dangerous. It's much more dangerous giving it to somebody who just has a little bit of an elevated cholesterol level and has no cardiac risk. There is good information that our profligate use of statins in the United States, which is true, we use more than anybody else, is not associated with better outcomes. In fact, it's with worse. That if you look at guidelines from the United States versus from England versus from Scandinavia, France, wherever, New Zealand, our guidelines push statins more than twice as much as any other country, and models of efficacy show that it has less impact. than at other places, because we're doing it all based on getting the cholesterol level as low as possible, which means you have to treat everybody and you have to give huge doses, and that's not how statins work. Statins work for some other reason that we're not really sure what it is, and it should have nothing to do with, or almost nothing to do with cholesterol. So I think it's a bigger issue, but in this case, it's probably not terribly
So
important.
the real thing to me about this that Jerry kind of brings up here is if the CMS is going to be polluted with these pay for performance criteria that we should really all agree on, that should have some pretty good evidence base behind them, if they're going to become a vehicle for big pharma to sell drugs, if big pharma is weaseling its way in to the CMS pay for performance criteria, I mean, certainly big pharma has weaseled its way into my scientific literature from the academic side. I mean, Gusto, let's tell the truth. What was Gusto? Gusto was an advertisement for TPA. They wanted to pretend it was a study. If it was an actual study, right, they said that if it wasn't a 1% difference, they were going to say it wasn't good. They got a 0.9% difference. Now, I'm pretty sure that means it wasn't a 1% difference. The conclusion should have been lytics don't work.
Anyway,
It
there's a
turned
lot.
into an advertisement.
You should. I mentioned this the other day. There are many, many examples. We don't have to go all of them, but I mentioned the other day that guidelines in the United States are written by experts. And how do you get to be an expert? You do a drug company study. And so most expert guidelines from most of your organizations and mine, whether it's in emergency medicine, infectious disease, cardiology, psychiatry, or whatever, most of the panelists, over 90%, are taking money from the drugs that they're recommending. And that's fine if the drugs are good, but in many cases they're not good. And that's, I think, for me, is one of the big hidden gorillas in this room is how's the CMS going to get its panels? It's going to do the same thing. And in fact, the drug companies, which now spend about $20 billion a year trying to get us to do what they want, and there's all these scandals about what they give to us and, drug reps and all this other stuff. There's scandals every day about it. Well, I think they're going to be really smart once this all happens. And they're going to say, you're right. We shouldn't do that. Why cloud the waters? We're no longer going to go give doctors gifts. We'll just by the people who sit on these guideline panels. And that's all they're going to have to do. It's going to be much more efficient. And if they give you a pen, you might write clopidogrel. There's evidence that we will when they give us things. But some of us don't, and it's not really efficient, and it's but if your pay gets dependent on it, you bet we're going to write the clopidogrel. So I think, I'm betting that when this becomes a real fundamental thing in the United States, we're going to see a sea change, and that's one of the big issues here is how much are what we do going to be dependent upon somebody selling us something? I think that's a real problem that we're all going to have to look out for.
All right, so let's change venues. That's kind of the end of the ACS one. It's not terrible stuff. I can live with that kind of stuff. Pneumonia is the next one. And I remember Diane does some journal watches, kind of like the abstracts, where they review papers, and then there's these little editorial comments. And I remember she wrote some editorial comments, and then there was this reaction from the infectious disease community where Diane basically said that the blood cultures stink, and then that last we checked, that pneumonia was in the lungs. And not in the blood. We know that the blood goes to the lungs, but we don't think that's really the best place to look for this. And then there was this aggressive reaction, and basically Diane was very polite in the first round, and they threw some stones at her. And I remember seeing the stones go by, and I remember thinking to myself, I wouldn't do that if I were you, because I know Di, and Di was not going to sit by. And so Di, why don't you tell us the rest? So she threw some bigger stones back. It was very entertaining.
What's interesting about all this, just to step back a second, the reality for all of us in this room is, right now, this stuff exists, all these for MIs and pneumonia and patient safety and all this stuff. This exists right now, and the reality is we have to get on, you cannot tilt at this right now if you want to get paid. Separate from that, though, is it is worth tilting at things in the background. So don't go ahead and jump through the hoops you have to jump through to get paid, but if the drug industry starts to influence this stuff, or if things get written like blood cultures
Before the first antibiotics.
dose of antibiotics in patients diagnosed with pneumonia in the emergency department, that's insanity. That is insanity. And what happened, just as a sequence, is I reviewed an article that talked about blood cultures in general, and then in my little commentary, very blithely just said, I think this is minimally useful on non-critical patients, and the data supports that. And it is extraordinarily expensive as far as the use of resources. We could immunize people across the country for the amount of money we're spending on blood cultures, $150 a pop minimum.
And that doesn't count the sensitivity.
Right. So,
Another $200.
So I wrote an editorial about this and got a blast back from all of the IDSA pneumonia guidelines people who are the consultants who went to the CMS to determine these seven scope of practice guidelines. And it led to a back and forth bunch of editorials that ended up in things like Academic Emergency Medicine and Annals of Emergency. Ron Walls got involved in this. But the good news is this got fought back enough to the point where if you look very carefully in the CMS 7 scope of practice newest iteration, it's only ICU patients that need to have the blood cultures before the antibiotics are given. It is not the ward patient. It certainly is not the discharge patient. It never was, but the problem is that we were never sure from the get-go who was going to be admitted, who was going to be discharged, so we drew all these cultures everywhere. We had them all over the place. So the pneumonia guidelines, the blood cultures are still there. If you read carefully, they're only people who go to the ICU. Make sure your hospital knows that, though, or you're going to get dinged and whoever extracts your charts. So the blood culture thing was an interesting sort of offset. My latest pneumonia thing that makes me whacked is the initial antibiotics within 4 hours of showing up at triage. The reality is, a lot of us, some of us can do that. Okay, they show up at triage, they get brought right on back, they get registered in the back, you see them in a half an hour, you think they have pneumonia, you can, fine.
Get a chest x-ray,
Have at
it's
it.
all done.
For those of us that work in hospitals with our average wait is 6 to 8 hours now. We had 5-hour wait just to go from the window to seeing a nurse earlier this week because we had 100 people just out in triage. I mean, it gets kind of whacked. Can I do this 4-hour thing? Not. So what it has led to in our institution is now anybody with a cough or a fever gets bumped to the front of the line. This is now in front of the chest pain person. This is now in front, they get bumped to the front of the line. They get basically a special scoring system and taken right to x-ray. If they have a positive x-ray, we usually isolate them because we have a high TB risk rate, but they also get a PO dose of antibiotics as they're getting put in the room and their blood is getting drawn for blood
Tail
cultures.
is wagging dog.
It has, because we got dinged hugely for not meeting this 4-hour deadline, this 4-hour goal thing. And now what it's doing is causing this incredible switch. There are hospitals that are giving PO levaquin in the waiting room to people who have a cough and a fever to make sure that the antibiotics are given
My
in
favorite-
our window.
my-
It's insanity. It's crazy.
My favorite is a hospital that I know of where apparently they're putting topical antibiotics on wherever the blood drawing sites.
No.
And they're then saying if somebody later decides it was pneumonia that they gave an antibiotic. That's actually as
Ooh, I like it. Gaming the system.
as far as bizarre as that is.
Does that count?
I don't know. That's better than the alternative. So Diane just pointed out that there are unintended bad consequences of stupidity. And one of them is, she said, you may do triage where you're taking a URI and making it into ahead of a chest pain. But what about the other really bad consequence? How much effort have we been spending, our government been spending, to try to get us to decrease antibiotic use in upper respiratory infections? You can't do that under this system. You're going to get dinged if you didn't give it. If there's any question, it might be just give them the antibiotics.
Bronchitis and a
Right.
fever,
The other
get the
thing I heard-
antibiotics. That's the people we're supposed to not give them
Right.
to.
Another
terrible.
solution I heard to this in an ER recently was that the nurses, because they get busy. I mean, our ER nurses work their heinies off. They work so hard. They're an amazing group of people. But the nurses were one of the steps where that 4-hour window got broken. So what they did is they incentivized the nurses to do this by giving them a bonus. For every patient they took care of who got the antibiotics in 4 hours, they got a bonus. So what happened? The nipride drip got put on the back burner. Oh shoot, I'm on my way. Oh, let's go get those antibiotics. And that sick, person who needed pressors waited till the antibiotics were given to the person down the hall because they were incentivizing the nurses financially. It's just gotten completely wild. And and in the science picture of this, there's no magic to 4 hours.
Yeah.
The 4-hour window as a magic number is that in and of itself was pulled out of kind of the air.
Thin air.
And that's his point in the back, is that there are some people where it really matters. Antibiotics
Should
right
do
now.
better than 4 hours.
We can't prove it, but right now probably it makes a difference. The person who's hyperacute, and the person who's very sick. So you probably need both of those. They need to be sick, and they need to, if they've had pneumonia for 6 days, what does an extra couple hours make a difference? But there probably are some, we'll never prove it, who really do need that. And of course, this is a good goal to get to. If I have a sick patient, I should try to give the antibiotics now. One of the things that I think we've had a sea change in our emergency department over the 15 years because of some studies that Dave Talon did a long time ago about time to antibiotics and meningitis is the notion that, I work in an academic place, the culture used to be, well, the team will decide they want to pick the antibiotic. We see somebody who needs an antibiotic for a presumed infectious disease, we give it now. We give it right now. We're trying to do something that Billy has taught us, which is to think about antivirals too in many of these patients. But that's a really good thing. But to then say, to go from that to this type of measurement where we're going to start way overusing antibiotics,
Your hand was up.
that's not a good idea.
Is Medicare still, with their DRGs, if you culture out, get a blood culture, culture the bug, you're paying more.
Yeah, don't let that get in the way of your payment. If someone comes in with a lobar pneumonia community acquired, call it pneumococcal pneumonia. If they're a 14-year-old with bilateral disease, call it Michael. The actual name doesn't have to be correct. Naming it increases your reimbursement. Just call it Bob. You don't have to be right. A lot of times with mycoplasma, it never grows out anyway. It's a fastidious
This is the
organism.
gaming of the
Just
system.
call it
That's how you game it.
mycoplasma. They're young. It's bilateral. Call it. They're HIV positive. It's PCP pneumonia. It might be TB. Who the hell knows? It might be MAC. You don't have to be right. Just name it. Never leave a pneumonia unnamed. No, you need to name
You
it.
need the bug.
You need
to
the
get
bug.
more, to get paid.
To get paid more, if you want to look at the DRG stuff, naming it. I don't ever let what
I
the
like
final
Bob, actually.
cultures.
Bob is good. I like Bob.
I like Bob pneumonia.
You know,
It's
that
good.
would be good because then CMS at some point there'll be somebody who's like, we're just getting all
What
these
is it?
Bob
What is
The
Bob
pneumonias.
pneumonia?
the CDC
What-
will be
what
calling me
is
to
that?
find out what happened with Bob. And is Bob a new prion?
We've had a new epidemic of Bob pneumonia,
It's a bobbage.
particularly in Southern California.
Yeah. Just
Or
so,
people who have
so you're
attended
right that
abscess
the naming of the pneumonia changed your reimbursement. And when I learned that, I was like, fine, I'm just going to name them all, whatever I think they are. You're an alcoholic. You got some bloody Klebsiella pneumonia. That's what I'm calling it. I mean, I don't care if that's what it turns out to be. I'm certainly not going to let my failure to come up with a bacterial name stand in the way of me and the money.
Alrighty then.
That counts as a half rand. That doesn't get a full one.
Yeah, fed
I
demi
like that. I
rant.
want to know where the duct tape went. There was duct tape on this table yesterday. I want it back.
Anyway, so with the, go ahead.
One and then.
Yeah, of course. Shit, yeah. Name it.
It's actually, it is kind of interesting. The gaming of this is fascinating. It's like when you document a laceration, you're going to game it so that the biller can do it quickly. 2.5 centimeter, simple repaired laceration to face. Tick, 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 billing is easy. It's the same kind of thing. You're gaming the system for them to be able to say, yes, you
And when
jumped
would
through
you ever do
hoop.
that? You're nuts. You should actually debride a few flat globules and call it a complex 2.5 centimeter laceration since it pays so much
And
more.
God forbid it would ever be 2.25 centimeters because there is no such thing.
Well, 2.25 fractions? You got to go with the decimal system here. Anyway, so with these pneumonia papers, again, there's some simple things we would agree with. Oxygen assessment, pulse ox, sure. I'll give you that. I think that's a great idea. It's probably the most important thing, probably even more important than the x-ray. Blood cultures, is it evidence-based? I think you know the answer to this. There's a whole bunch of papers there that say it absolutely is not evidence-based stuff. And so don't get wrapped up into that. What about what are the other things they want? So we talked about the 4-hour rule.
Antibiotics and the right antibiotics. Make sure one thing Rick did for you was in the back of that chapter are the right antibiotics as of now. Okay, that will change, and since we're going to have levaquin resistance at this rate in a matter of short amount of time for all this levaquin that's being given, but the antibiotics need to be appropriate. Yeah,
Sorry to beat that horse, but
beat it away.
if the goal of the blood culture is to identify unresponsive pneumonia, why does it matter if you get it before or after the antibiotic?
The IDSAs feels very strongly that the antibiotics need to be, the blood cultures need to be done in sort of the milieu of no bug juice to help them make their decisions on what is.
Culturing and sensitivity is a lot
Right,
harder
for
if
the
the first dose is on
right.
board. If you want to be a purist about this,
If you're gonna
it's
do
no
it, you
question
might as well
that the
do it right.
culture rate depends a lot, and we've done this in this course. It depends a lot on if you want to talk about blood cultures, it depends a lot on how much blood you take. It depends a lot on whether they're previously treated. It depends a lot on what you specifically ask them to culture for. If you're worried about specific things, you need to ask for it.
Just to be fair to you, however, we don't really know how long it takes for you to have
No.
IV antibiotic in your blood before you're going to
sterilize it.
affect the blood culture. We do know in terms of meningitis, there's pretty good evidence that it takes at least a few hours before there's any effect at all. And that there are many ways you can tell what it is anyway using the serologic tests in meningitis even later. But so we don't really know for pneumonia, and it's undoubtedly true that if you were to give them the shot and then take the blood, it would be no different. But 2 hours for who knows exactly what it is.
But the other question is if they're getting better on the antibiotics you're on in 2 days, and you're going to get.
Well, that's for sure. That's part of
Which
the
is
reason why
why-
blood cultures are
Right, which is
so
why I think
worthless.
they backed off and said, actually, for the new approach to pneumonia, which is don't identify the bug, identify the milieu. What's the patient's milieu? What is their potential exposure? And then empirically treat. That is absolutely clear that is a better approach than the old way of find the exact bug and treat the exact bug. But it does get to a point where there are the complicated patients, the patients that are in nursing homes, the patients that are alcoholics, that come in sick, where the actual bug may very well be important to their outcome. And then I think in those cases, that's why I think they're backing off to the, okay, just do it in the sick ones, where it really may make a difference, whether we need that, pseudomonal coverage for sure or not, may be very helpful.
And there,
The question is if I'm treating a bug, if I'm given a receptor shot in the ED, and then I do a blood culture, and the person is not getting better in 2 days, is that receptor shot going to affect the culture directly, or does it mean that I'm not treating the right bug?
so what you're suggesting is that that's a wonderful irony that you've just pointed out, that if they're not getting better, the thought is because the bug isn't sensitive to the thing you're treated them with. So then why would it have been sterilized? It's a really good, nice little irony. Sure, if it's because it's the wrong bug, it's the wrong antibiotic, then you expect the culture would still be positive. That sort of makes sense. You should also know that blood cultures are positive, only 5% of pneumonia, and most of those, when they turn out positive, you don't change anything. You've done exactly what you were supposed to do anyway.
Although they are high, in the sick person with pneumonia, the rate is 18 to 25% positive. So that truly septic pneumonia case, that is the case where you're more likely to be positive and more likely to have it have an impact on their antibiotics. So started out on 3 or 4 to start. You would like to narrow it down to what you need.
Right, but
And then the last-
a great point, which is that if they got better, who cares?
Yeah.
And if they didn't get better, ostensibly it's because you didn't kill the bug.
The last thing I have to point out, and Diane and I both work in a county environment where there's just not enough money to go around. I mean, we don't have enough beds. We're rationing resources all the time. And there's no place more than the emergency room where resource stewardship affects the entire healthcare cost of patient care. And so there's a paper in there that's titled Shoot, Ready, Aim that I like. It's by Milo, where they pointed out that actually that blood culturing everyone with pneumonia results in needless expenditures. It results in losses to the system. That not only is it not really evidence-based, but it's a financial disaster for the system to use blood cultures as a driver. False positives equal true positives. That's one thing about it. And they miss a lot of the organisms that we care most about, like Legionella and things like that. If you want to talk about the sick pneumonias that would slip out from underneath you, the blood cultures stink at those. And so this paper points out that blood cultures are not only evidence-based wrong, but they're stewardship wrong. And the stewardship wrong argument to me is far more pervasive, which is why for someone like me who works at a county hospital where I'm resource rationing, I'm not doing it. I don't care who says they're going to pay me. I'm not getting paid anything for working at the county anyway, hardly. So, but I'm not doing it because it's wrong from that standpoint.
So that does raise sort of an issue for all of us, and I think that I'll just sort of mention. There are two sides to this as far as I can see. One is the train has left the station. They're going to pay us or not pay us. we got to go along with this. And that's a pretty persuasive argument, not pervasive, Rick, Billy.
Persuasive, I heard you. It's both pervasive and for some people persuasive.
It's a pretty persuasive argument, and, you know, we don't want to be morons who are just going to, you know, stand on the rooftops and scream and be silly, because they've already done this and it's already happening. On the other hand, I do think that we have an obligation to care about our patients and about the public health, and to the extent that some of these things are really harmful, I don't think we should just say, well, it's too bad, get with the system, do it, there's nothing, you can't fight City Hall. If anybody's going to fight City Hall, it has to be us. So I do think we can't fight all of these, and we should only pick and choose the ones that really matter.
That's a windmill to tilt at.
But I do think there are some times where we need to get together and say, this is really a bad idea, we're not playing. I really do think that. And we have to first agree with each other, what are the important ones, and we have to have a mechanism to do that. And I don't think we can do that as individuals. We would have to do that as a group, as a specialty. We do have people, representatives who represent us for our specialty. And I think when things matter, it's important. It will be continuously, from time to time, it will be important to identify something that we're going to just have to say no.
Well, and it's worth, and just as an offshoot, I mean, I feel very powerless sometimes in these things. It's like, it's just getting shoved down my throat and there's nothing I can do. There actually are things you can do. And although it involves time and sometimes money, you need to get involved.
And organized medicine is usually the vehicle.
Is the way to do it. And I'll tell you why that kind of thing is important. The very last part of this chapter, what CMS did, JCO did, AMA did, et cetera, is went to our parent organization, ASAP, our trade organization, went to actually everyone, the AAP, the American Society of Anesthesiologists, et cetera, and said, you choose for your specialty quality measures that we can use for pay for performance. We can use for quality. So there was a committee from ASAP that submitted the things that are listed right here in the end of your book. If you had been involved in that, you might have had some input, because there are a couple things on this list that make me want to scream. For instance, EKG performed for all non-traumatic chest pain under the age of 40. Your costochondritis, or over the age of 40, your costochondritic 42-year-old, if you did not get an EKG, you must explain it. EKG performed for syncope in all patients 18 or older discharged from the ED. Your vasovagal syncope in the person who was standing at the graduation of their kid, and they faint, if you don't get an EKG, you have to explain it. If you don't like these sorts of things, these are things we could have impacted from the front end if you're involved.
That's a great point. There are some other things that are a little bit off the topic, but that are really crazy that they're asking us to do. So, for example, CMS has this thing right now that all drugs in the ER have to be approved by a pharmacist.
And reconciled.
Reconciled by a pharmacist. How many of you are taking timeouts? Where you have to make sure, there's this new policy.
Patient safety initiative, the universal protocol.
So
that's the section right before the end. All the initiatives that apply to us in the ER they're listed here.
So in the LA Times today, there was something about a man who goes public that they cut off the wrong testicle. Well, I'd be pretty pissed if they cut off the wrong testicle too, because they can't leave in the other one. Now we got real problems. He's got cancer in the other testicle. So you'd think, okay, if I was that guy, I'd be really unhappy. But one of the rules about fixing things is first identify what's broken. So we have this whole big patient safety movement, which sort of says, the Institute of Medicine said, you're killing all these people. It turns out it's mostly baloney, but we do make errors, and we should have system changes for them. But before we start making widespread changes, how about thinking what's broken? In the ER, is it really a problem that you sewed the wrong arm laceration? I meant to sew the arm with the laceration, but I actually sewed the one without it.
Cut.
Some of these, okay, maybe in the OR they should have a mark. Which testicle do we really want to take while the patient's awake and can tell you? But, I cracked the wrong chest. This guy's dead, and that guy, we had to hold him down so we could crack his chest.
Although I listened to you say this last time, Jared. I have to say, Timeouts are ridiculous for certain things.
It's just great
There
humor.
is one
You
head
can't buy
with
that
one
kind of humor.
laceration on it. It needs to be sewn. That's ridiculous. However, Billy and I work in places, you told a story, I had a similar story, where we'll get 2 or 3 gunshot wounds to the chest at the same time. So we have a bunch of chest x-rays floating around and a bunch of things floating around. And actually, it is well worth a timeout to make sure you're putting the chest tube in the right guy.
Or that you looked at the right x-ray
Right.
and that it
You-
wasn't
you
up
double
backwards.
You double check the.
I'm all for careful, but let's not just do a blanket shotgun
agree with
thing.
that entirely.
I mean, some of these are really, really absurd, and sure we should try to do system things. The more chaotic it is, the more checks you need, of course.
Well, it's
But
always
some
good to get a
things- some of
timeout
this
before
are
the LP in case you were going to lumbar puncture the left spine. Because,
Which side?
Yeah. That's, in fact, I've noticed that problem. When I miss it, I must be on the wrong side.
And you are.
Yeah, exactly. Either side is the wrong side now. So in this, what's kind of left in this thing to look at are all of the safety recommendations. And by the way, Jerry's asked this question. We should fundamentally ask what's broke before we fix it. And decide which of the fixes, do you want to fix the overpass that's about to fall and kill 50 people, or the pothole that's an annoyance to the motorist? And some of these are pothole fixes when the overpass is busted. If you look at the Institute of Medicine report, which we all agree has lots of problems, and tried to tease out what matters, where are the problems happening, where that error rubber hits the road is drugs being given and doses being ordered. So if you think that there's some Nazi going around telling you not to use Acute Day and which abbreviations are forbidden and those kinds of, that actually matters. And even when you try to do your best, and I love to tell a story, this is where even despite your best attempts to comply with this, you get it wrong. This happened not too long ago at our hospital. 2 patients, name bands on, nurse busy, he's got the penicillin in hand. We still use penicillin. I know that's shocking to many of you that someone would consider such an archaic drug, but we still use it for some things. And she walks up to the patient whose name is spelled W-R-I-G-H-T, and she says, you're supposed to get she says to him, your name is, you're here for the penicillin, right? He says he's telling her the name, so he says, right. And so she ends up giving, so even though she asks and goes to correlate that she's doing her best, the wrong patient gets the penicillin. Because when she asked, are you so-and-so, that's what she said. She said, are you Mr. Carroll? And he said, right. Meaning, no, I'm not Mr. Carroll. He said, I'm Mr. Right, but all she heard was right. W-R-I-G-H-T. And up the drug went. Fortunately, he didn't have anaphylaxis, but it was just one of those things where when you looked at what happened, you're like, great, even the best tested things. And then the other ones that are kind of really amusing to look at, well, maybe not so amusing, are the patient satisfaction initiatives that they're going to ask patients during the hospital
This is
stay.
voluntary so far. the reporting
Voluntary in
is.
2007, but do you know when they say voluntary, it's
Not so
coming.
much.
That's the sound of the train leaving the station. And they're going to ask things like, how often did the doctors treat you with courtesy and respect? We already know that they don't know who the doctors are. Particularly for the women. Even in the emergency room, our female residents are with the patient for hours. They're like, when am I going to see the doctor? It's like, hey.
I just had that happen the day before yesterday.
We have to tell the nurses, and our nurses wear scrubs. They look just like doctors in our ER. You can't tell them apart. So we
I even
often
had my white coat on the other day, and the patient said, after 8 hours, am I stopping by every, half hour?
Yeah.
Am I going to see the doctor?
Yeah. How often did the doctor?
Hello?
Yeah.
That's right, exactly.
Or a mail tech, or any mail.
Grab any guy. Yeah, exactly. Can you just stand there for a second and
And
say,
so these patient satisfaction things, they're really going to start getting into it. Did you give pain meds? Were you courteous? This is,
did they listen carefully to
I'd
you?
hate
Not
to
just
think
listen,
that
but listen
payment was going to
carefully.
become a popularity contest, but some of this is in there, and it's a little concerning as to about, where's the science on this? I mean, we can argue about the blood cultures at least. There's some, and yes, of course, we should be professional and nice and courteous, and we should treat pain aggressively and things like that. But, to turn Press Ganey, the process which has frustrated many a doc on the first floor, into a hospital-wide process is something that's a little bit frightening to me, but there it is. There it is for
That
you.
was relatively mild. That was.
A mini rant.
Yeah, that
wasn't
didn't,
even
no
a
duct
rant at
That
tape,
wasn't even a rant.
no blow darts, that was. no.
Yeah.
What do you
Okay,
guys-
any
yeah,
other
yeah,
comments on
please.
this before we
They're gonna
finish?
make that call 30 days after the visit, which is right after they get the bill.
Yeah, that'll warm them up.
Actually, one of the best,
Dr.
the-
Purdy is,
yeah.
no, not 30.
One of the best gaming of the systems I ever heard from a hospital was they have a system where every patient who was discharged within the past 24 hours gets a call the next day by a nurse that's assigned to do this, who starts the call with, yeah, before the bill, before anything, starts the call with, so, did you enjoy your excellent care here at X whatever hospital? And the answer was yes, and the check mark got made, and excellent was the, thing that was checked in the box. So
But-
it's.
But that's a great idea, by the way. Forget about
Yeah,
the
the calling is
baloney.
good.
Calling, I don't know if any of you
Patients
guys
love it.
have this, where you call back. There are
Even from
places
the
which
ER,
do it for
yeah.
every
Oh, yeah.
every patient, and that's really hard. But it's fabulous if you do. Patients are so grateful because we always look at things from our own point of view. But just imagine for them, it's scary. They're in pain or they're nauseated. There's some reason they don't know what's going on. They're frightened. They go to a place where everything is crazy. They don't know who's taking care of them. Things are hurried. They wait a long time. Something happens. They're not sure exactly what it is. This is not a great experience. No matter how hard we try, it can be a really bad experience. To the extent that you can give them the sense that you actually did care about them, that you are paying attention, I think that's, it's more than just satisfaction scores. It's satisfaction.
Plus
That's
the
really
callback.
important.
We leave them intentionally with sort of questions unanswered, like if it gets worse, if you have new symptoms, if this, if that, and we tell them the radiology report is a preliminary read. The expert will read it later. If there's a difference, we'll notify you. When you call someone back, 12 hours or 14 hours after that and say, yep, the radiologist read the x-ray, they agreed, and
How you feeling?
how are you doing? And they say, I got this. You say, oh, I don't think that's much. It sounds like you're getting better. That it really does close the loop on a lot of this.
Right.
I mean, we intentionally are careful about telling patients what to expect. We've told a whole generation of doctors, never tell them everything's all right there, sweetie, it'll be fine, because sometimes it isn't. That the setting of expectations too high is part of the cause of medical malpractice. So we leave it all open-ended and sort of fishy, and calling back does make a big difference for people.
Great idea.
Yeah.
I encourage you all.
Go ahead.
Is it one blood culture or two that's required?
Two.
It is two.
I say get one and split it. You don't want them to grow anything out
Actually, all you
anyway.
do is you get a few drops of blood and dribble it in the bottles.
Yeah, get one and
yeah.
split it.
You make it vanishingly small. 4 blood cultures, no CCs each.
Yeah, no, we're drawn.
Yeah, exactly.
And you know what else is interesting though about it, at least as I understand it, and Di, correct me if I'm wrong. The order for the blood cultures before antibiotics is what they look for, not whether they were actually obtained.
Well, if you really, yes, the order should be written in that order. Yeah.
They're checking the times on ours because.
Are they? Oh, see, you need to fire those people and get people that are not as good at their job. Beautiful.
All right.
Yeah.
And
All right.
what's the next talk?